Everyone, welcome to researchmd.com. We got a great presentation today. Today we're going to teach you everything about an important topic, idiopathic intracranial hypertension, which is also called pseudotumor cerebri. Okay, again, my name is Pramil Cheriyath. I'm a program director, internal medicine residency program, transitional residency program, director of research. I'm also assistant professor of medicine, and I teach medical students and medical residents. So let's get into our subject. So what is the definition of idiopathic intracranial hypertension? So it is characterized by elevated intracranial pressure without any established cause. Okay, elevated intracranial pressure without any established cause. Now, so if you look at the pathophysiology, there's three things actually happening. There's impaired CSF outflow. Okay, the CSF outflow is obstructed. Venous sinus stenosis leading to increased venous sinus pressure, and the third one is there is cerebrospinal fluid hypersecretion. Okay, all of this kind of leading to elevated CSF pressure and causing all our symptoms. Now, risk factors: women of reproductive age, obese female, you have to be careful. If you have polycystic ovarian syndrome, is associated with it. Again, it's also associated with obstructive sleep apnea. Now, medication history, be careful. Excessive amount of vitamin A and retinoids have been shown to have associated with pseudotumor cerebri or idiopathic intracranial hypertension. Now, what are the symptoms people usually present with? The number one symptom is like headache, and then pulsating tinnitus. See, people hear this swishing sound like that in the ear. Pulse synchronized with the tinnitus. There's going to be transient visual darkening, and then you can also have like dizziness or balance issues will be noted. So if you look at the signs, always first thing you need to make sure check for the visual acuity, and also you do a fundoscopy, look for papillary edema. It's also with the sixth cranial nerve, which is the abducens nerve. What does it do? It is, it controls the lateral rectus muscle. Okay. So when you look at when you ask the patient to look to the peripheral vision using this eye, let's say the right eye affected, because of the abduction is affected, they won't be able to abduct. Okay. So what is the other guy is going to do? Other eye is going to do this guy is going to move to look to the side. Okay. So abduction is affected and the lateral rectus muscle is affected. Okay. So visual field defect, you can see enlarged blind spot and the loss of nasal visual field. Generalized visual field constriction is also seen. When you look at the fundoscopy, you always see the papillary edema. We got a nice picture over here. And then CSF analysis, you do a lumbar puncture. Normal CSF pressure is between 7 and 18, and in this patient, you're going to have CSF pressure like greater than 25 centimeter water pressure. Now, if you do an MRI, which is required in this group of people, you will see the number one finding is the flattening of the posterior sclera, empty cell, distension of the perioptic subarachnoid space, enhance of prelaminar optic nerve, intraocular protrusion of the prelaminar optic nerve, and vertical tortuosity of the orbital optical nerve. Again, if I have to take something out of this slide, the number one finding is going to be flattening of the posterior sclera. Okay. Now, medical management, acetosalamide, it's also called Diamox, is a carbonic acid anhydrase inhibitor, decrease the fluid, and number one treatment. And then you can also use topiramate as a role in it. And always when the risk for obese patient is really high, so weight management is the other lose some weight is also the management. What is the surgical management? Don't pick an answer like there's no, in the olden days they used to do like CSF drainage, but what they found out, if you do drainage, take the fluid off, it was building up in 4 to 24 hours. So it was not working. So don't pick an answer for that. Only two options here. One is optic nerve fenestration. The other one is CSF diversion with the VP shunt placement. Okay. Now, what are the long-term complications? It can lead to visual loss and can even also lead to blindness. Again, thank you so much for watching our channel. Please subscribe to our channel so we can produce some more videos like this. Again, thank you so much. Bye.